If you've been swallowing a blood pressure pill every single morning for the past year, amlodipine, losartan, or lisinopril, let me ask you something, and I want you to answer it honestly in your own head before you say a word out loud. How confident are you right now that you actually understand what that little pill is doing inside your body? Not what the label says, not the single rushed sentence the pharmacist stapled to the bag. I mean, truly understand it, the way it works, the way it can quietly turn against you under the wrong conditions, and the warning signs that separate a small, manageable nuisance from a situation where every minute matters. Most of the people I sit across from, smart people, organized people, people who balance a checkbook and read the morning paper cover to cover, go quiet when I ask that. And that quiet pause tells me everything I need to know. Because here is the truth nobody seems to say plainly. These are not weak little pills. They are not vitamins. Amlodipine, losartan, and lisinopril are powerful medications that change how your heart, your blood vessels, and your kidneys behave every single day you take them. And yet millions of seniors take them half asleep, on autopilot, with almost no idea what to watch for, what to avoid, or when something that feels completely ordinary is actually an urgent signal their body is desperately trying to send. So here is what most people never realize, and it's the thing I want to fix today. The danger with these three medications is almost never the drug itself. The danger is the silence around it, the gap between what you were prescribed and what you were never told. My name is Dr. William, and by the time this video is over, you are going to understand these three medications in a way that makes you safer, calmer, and far harder to catch off guard. Before we go 1 inch further, do me a small favor. Drop your first name and the town you're watching from in the comments. I read them, and I genuinely like knowing who I'm talking to. Now let me tell you about a man named Walter, because what happened to him is the perfect place to begin. Walter was 74 years old. A sharp, methodical, retired engineer who treated his health like a project plan. He never missed a dose. His daughter had set up one of those pill organizers, Monday through Sunday, and Walter ran it like a man who used to manage construction schedules. So when his doctor added amlodipine to his routine, Walter shrugged. One more blood pressure pill, he figured. Same family, different name. No big deal. That single, quiet assumption nearly cost him an entire good year of his life. Because 3 months later, Walter's feet had swollen so badly he couldn't squeeze them into a single pair of his own shoes. By 4 in the afternoon, his legs felt like sandbags. He started walking less, then less again, because every step made it worse. He told his son he was sure his circulation was failing. He was frightened. He sat up at night Googling the words heart failure. And here's the part that breaks my heart a little. The real answer was something far simpler and far more manageable than the catastrophe he was imagining. But Walter didn't know that because no one had ever explained to him the single most important fact about these drugs. Amlodipine, losartan, and lisinopril are not the same kind of medication. They all lower blood pressure, yes, but that is where the similarity ends completely. Let me give you the key that unlocks all of this in plain language. Amlodipine is what's called a calcium channel blocker. Picture the walls of your arteries as muscle that can squeeze or relax. Amlodipine tells that muscle to relax, so blood flows through with less resistance and the pressure drops. Lisinopril works in a totally different place. It's an ACE inhibitor, which means it blocks a specific enzyme in your body whose job is to tighten your blood vessels. Block the enzyme, and the tightening eases off. And losartan is what's known as an ARB, an angiotensin receptor blocker. It works in that same blood pressure system as lisinopril, but it slips in through a slightly different door, and that small difference matters far more than most people would ever guess, as you'll see in a few minutes. So sit with this. 3 different mechanisms, 3 different side effect personalities, 3 completely different things to watch for. The moment you understand that, You stop reading every twinge in your body through one blurry, one-size-fits-all lens. Walter's swelling was never heart failure. It was amlodipine doing precisely what amlodipine is known to do in a real percentage of the people who take it. And the medical research is crystal clear on the why. Here's the mechanism, explained the way I wish someone had explained it to Walter. When amlodipine relaxes the small arteries leading into your legs, blood pours in more freely. But the veins, the vessels responsible for carrying that blood back up toward your heart, don't relax in the same way. So you end up with a traffic problem. More blood flowing in than is flowing back out. Pressure quietly builds in the tiny vessels around your ankles and feet, and eventually, that pressure pushes fluid right out of the vessels and into the surrounding tissue. The result is exactly what Walter saw: puffy ankles, socks that leave deep red canyons in your skin, shoes that mysteriously stop fitting, legs that feel heavy and waterlogged by late afternoon. And this is the part I need you to underline in your mind. This is not your kidneys failing. This is not salt retention from last night's dinner. This is not the beginning of heart failure. In the vast majority of cases, it is a predictable, well-documented physical response to how amlodipine works. The medical literature even shows it's dose-related and noticeably more common in women and in older adults, which is exactly why so many seniors meet it. But here's where it gets genuinely dangerous. And it's not the swelling, it's how people react to the swelling. Some folks see those puffy ankles and quietly decide, all on their own, to just stop taking the pill, and they tell no one. Their blood pressure climbs right back up in the shadows, while they feel like they made a sensible, grown-up decision. Others keep taking it, but start avoiding water, convinced they're retaining fluid, which is exactly backwards. Because getting dehydrated on a calcium channel blocker carries its own real risks. And some people, like Walter, simply suffer in silence for months, shrinking their whole life down to fit around the symptom, assuming the worst. So here is the move I want you to remember, the one that protects you. Leg swelling on amlodipine is a conversation your doctor needs to have with you, not a reason to panic. And absolutely not a reason to quietly quit. Because there are real options. Elevating the legs, adjusting the dose, or its timing. And here's something the research strongly supports. Adding an ACE inhibitor or an ARB can actually rebalance the pressure and calm the swelling down, while plain old water pills usually do almost nothing for this particular kind of swelling. But none of those doors open if you suffer in silence. So if you're on amlodipine, tell me in the comments, have you ever felt that heavy, swollen feeling in your legs by the end of the day? You may be stunned how many people are quietly nodding along right now. Now let's turn to Lisinopril and the most notorious side effect in its entire family, the cough. And not just any cough. A dry, scratchy, relentless tickle at the back of your throat that gets worse at night and laughs in the face of cough drops, lozenges, antihistamines, and everything else in your medicine cabinet. Here's what makes this one so sneaky. It very often does not start right away. Some people develop it in the first week. Others sail along for 3 or 4 months before it appears. And by then, the idea that a blood pressure pill they've taken without trouble for months could be the culprit never even crosses their mind. So they blame dust, pollen, a cold that never fully left, acid reflux, anything but the real cause. And I want you to meet Evelyn because she lived this. Evelyn was 71, a devoted gardener, and when the cough started in late spring, she naturally blamed the pollen. The timing seemed almost too logical to question. She bought antihistamines. She bought an air purifier. She mentioned it to her doctor, who ordered a chest x-ray that came back perfectly clear. 6 months later, the cough was still there, stealing her sleep almost every single night. She was exhausted, short-tempered, and starting to believe something serious was being missed. When she finally came to see me, One of the very first things I asked was simply this: when did you start the lisinopril compared to when the cough showed up? She went quiet, pulled out her phone, started doing the arithmetic right there in front of me. She'd started lisinopril 11 months earlier. The cough had crept in around month 4. In all that time, she had never once connected the two. Now, here is what the science tells us about why this happens, and it's beautiful in its simplicity. That same enzyme lisinopril blocks to lower your pressure also normally breaks down certain irritant compounds in your airway. Block the enzyme, and those compounds build up and tickle the cough reflex. That's it. That's the whole mystery. And here's the elegant part. The reason that slightly different door I mentioned earlier matters so much. Losartan, the ARB, works on the same blood pressure system but doesn't cause that buildup, which is why it so often doesn't trigger this cough at all. Once Evelyn's primary doctor switched her over, the tickle in her throat was gone in about 2 weeks. 11 months of wrecked sleep, undone in 14 days, the moment somebody connected the dots. But now I have to stop and draw a hard, bright line, because there is one symptom in this same drug family that is absolutely not a nuisance. It is a true medical emergency, and you need to know the difference cold. If you are on lisinopril or any ACE inhibitor and you develop swelling of your lips, your tongue, your face, or your throat, especially if swallowing or breathing starts to feel difficult, you do not wait. You do not call the office in the morning. You do not take a Benadryl and see how it goes. You call emergency services immediately. This is a condition called angioedema. It is rare, but it is very real, and it can close off your airway faster than you would ever expect. The medical data is sobering here. A meaningful share of people hospitalized for this kind of reaction end up needing direct intervention to protect their airway. So let this be the sentence you never forget. A dry cough is an annoyance. Throat or facial swelling is a 911 emergency. The gap between those two things could one day save your life, or the life of someone you love. And if no one has ever broken your blood pressure medication down this clearly before, take a second and hit that subscribe button, because what's coming next could matter just as much for your safety. Now let's move to Losartan, and a danger I find genuinely striking because it doesn't come from doing something wrong. It comes from people doing exactly what they were told was the healthy thing. Losartan, like lisinopril, works on your body's blood pressure control system. And one well-documented effect of this whole class of medication is that it can nudge the potassium level in your blood upward. For most people, monitored properly, that stays in a perfectly safe range. But stack the wrong everyday habit on top of it, and the whole picture changes. And here's where it gets counterintuitive, so lean in. Potassium isn't just hiding in bananas and supplements. It's hiding in a product marketed to seniors as the smart, heart-healthy choice: salt substitutes. So many of those popular low-sodium salt alternatives, the ones sitting right beside the regular salt on the shelf, often branded as good for your heart, simply swap the sodium out for potassium chloride. Do you see the trap closing? A senior is told to cut back on salt, so they buy the potassium-based substitute. They shake it generously over every meal, feeling virtuous. And all the while, they are pouring potassium into a body that's already running a medication which raises potassium. The research is direct about this. That combination, without awareness and monitoring, can push potassium high enough to disturb the electrical rhythm of the heart. And what makes it especially treacherous is that high potassium doesn't always announce itself loudly. Sometimes it whispers as unusual muscle weakness, a stubborn fatigue, cramping in the legs, tingling in the hands, or a fluttering, irregular heartbeat. And sometimes there are almost no symptoms at all, right up until the moment there are very serious ones. The medical sources are united on who's most at risk, too. Adults over 65, because kidney function naturally tapers with age, and anyone with even mild kidney trouble. So I want you to picture someone in your own life right now. Maybe it's you who switched to a salt substitute in the last year or two. If that person is also taking Losartan or Lisinopril, this is a conversation that needs to happen with a doctor. Not because the medicine is dangerous on its own, not because potassium is evil, but because the combination, left in the dark, can build a slow problem that never needed to exist. And it's not only salt substitutes. Certain electrolyte powders, some meal replacement shakes, and a number of over-the-counter sports recovery drinks carry surprisingly heavy potassium loads too. Nobody thinks to mention them because they're not prescriptions. And that is exactly why they slip through and cause trouble. Now I want to give airtime to something that almost never gets discussed, and it hits seniors harder than any other group. What happens to these drugs when you simply get sick? I don't mean a hospital-level illness. I mean a nasty stomach bug, a couple of days of vomiting, diarrhea that won't quit, no appetite for 48 hours, or just a brutal hot week with heavy sweating and not enough water. Here's the science of why that matters. When you're dehydrated for any reason at all, the exact same dose of Losartan or Lisinopril that was perfectly calibrated for a well-watered body can suddenly behave very differently. Your blood pressure can drop too far. Your kidneys, already straining from the fluid loss, become far more vulnerable. And the research specifically flags older, volume-depleted adults as the ones most at risk for kidney strain in these moments. Dizziness, weakness, faintness, even acute kidney stress can come on faster than you'd expect. And notice, the medication never changed. Your body's internal weather changed, and the drug is now operating in conditions it was never tuned for. So this is one of the most practical things I can hand you today. Illness changes the rules. If you don't have a plan for what to do when sickness hits, whether to hold the dose, when to call, what symptoms should send you in, you've got a real gap in your safety net. And that plan is something you want from your doctor before you ever need it. So here's a quick one for the comments. Has your doctor ever given you a sick day plan for your blood pressure medication? Just type yes or no. I have a strong feeling I know how most of you will answer. Here's another scenario I want you to actually picture. You've had a rough week. Your arthritis is flaring, your knees ache, your back is stiff. So you stop at the drugstore and grab some ibuprofen, something you've used for years, totally ordinary, sitting right there on the open shelf for anyone to buy. But now you're also on Lisinopril or Losartan, maybe even a water pill on top of that. And here's what the research shows about that combination when it's used regularly. Those over-the-counter anti-inflammatories can meaningfully cut blood flow to your kidneys, and in the setting of even mild dehydration, the risk of kidney injury climbs substantially, again, most sharply in older adults. This isn't some rare freak event. It is one of the most common, most preventable situations there is. And the reason it sails right under the radar is heartbreakingly simple. People don't think of ibuprofen or naproxen as real medicine in the same league as a prescription. It's just something for the pain. But here's the thing. Your kidneys cannot read the label. They don't know prescription from over-the-counter. They only respond to chemistry. So if you regularly reach for anti-inflammatory pain relievers for your joints or your back, and you take any of these 3 blood pressure drugs, please make that a conversation with your doctor. There are very often safer paths, acetaminophen, topical treatments, physical therapy approaches that don't carry the same kidney risk. You do not have to just grit your teeth through the pain, and you do not have to silently accept the danger. There's usually a better road. You just need someone to help you find it. Let me spend a moment on something that sounds tiny and absolutely is not. Dizziness. That brief wobbly moment when you stand up from the couch or climb out of bed, and the room tilts for a second. You grab the door frame, it passes, and you think, I just got up too fast. For a lot of seniors on blood pressure medication, that's a daily event, and it's almost never mentioned to anyone because it seems too small to bother with. So hear me clearly. In an older adult, a couple of seconds of dizziness is enough to cause a fall. A fall is enough to cause a fracture, and a fracture, especially a hip fracture, can knock an older person's whole health trajectory off course in ways that take years to recover from, if recovery comes at all. That isn't me being dramatic. That's physics and biology shaking hands. The dizziness happens precisely because your medication is doing its job in lowering your pressure. And when you stand up fast, your cardiovascular system hasn't had its half second to catch up. So blood flow to the brain dips for a moment, and you feel that lightheaded tilt. The fix is often beautifully simple. Rise slowly. Sit on the edge of the bed for a moment before you stand. Hold something solid when you get up. Give your body those few extra seconds to adjust. But beyond the practical fix, dizziness that happens regularly, that doesn't settle down after your first few weeks on a medication, or any episode of near fainting, those deserve a real conversation. The dose might need tuning. The combination might need a review. Your hydration habits might need a tweak. Silence on this one is not a small risk. Now let me settle something that creates enormous, needless anxiety and sometimes pushes people into genuinely dangerous, impulsive decisions. Your blood pressure is not a fixed number. It is not your shoe size. It moves constantly, every hour of every day, in response to dozens of things. How well you slept, whether you had coffee, whether you're in pain, whether you're anxious about the reading itself, whether you just walked in from the cold, whether you were talking loudly right before you sat down. So a single high reading on a random Tuesday morning after a bad night's sleep does not mean your medication is failing. And a single low reading after a hot, dehydrated afternoon does not mean your medication is suddenly too strong. What actually matters is the pattern over time, measured consistently, same arm, same time of day, after 5 quiet minutes of rest, without rushing or talking. When people instead monitor haphazardly and react emotionally to each individual number, the decisions that follow are almost never good ones. An extra dose taken in fear, a skip dose because one reading looked nice, a frantic phone call about a number that was, in context, completely unremarkable. So monitor with a method. Track it over time. Bring the log to your appointment. Let the pattern guide the conversation, not the panic. That one simple shift lowers your anxiety, sharpens your decisions, and hands your doctor something 1,000 times more useful than a single scary screenshot. And if you've made it this far and you're getting real value out of this, type the number 9 in the comments. It's a simple way to tell me you're here and following along. And that brings me to the single most important idea to carry out of this video, the number one principle that ties everything together. These medications work through one thing above all else: a steady, unbroken presence in your system. Not spikes and gaps. Not an extra pill when you're worried. Not a skipped pill because you feel fine today. Here is the reframe that changes everything. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are not aspirin for a headache. They were never designed to be taken reactively, in response to how you feel in a given moment. They are designed to hold a quiet, constant line in the background of your life, day after day, so that the dangerous pressure never gets its foothold in the first place. The moment you start treating a maintenance medication like a rescue medication, dosing by mood, by fear, by a single reading, is the moment you trade steady protection for a roller coaster. Consistency, not intensity, is what keeps you safe. The boring, faithful, same time every day habit is the whole secret. That's the number one rule, and it quietly outranks every single thing we talked about today. So let's bring it home. We covered Walter and the swelling that wasn't heart failure, and the rule that you never quit amlodipine in silence. You talk about it. We covered Evelyn and the Lisinopril cough that stole 11 months of sleep, and the bright line between a harmless cough and the throat swelling that is a 911 emergency. We covered the salt substitute trap with Losartan and potassium, the hidden kidney danger of casual ibuprofen, the way illness rewrites the rules, the dizziness that leads to falls, and the truth that your blood pressure is a moving pattern, not a fixed verdict. Now, here is what I do not want you to do. I do not want you to walk away and try to overhaul everything tonight. That's not how lasting safety is built. Pick one. Maybe it's finally mentioning that afternoon leg swelling. Maybe it's checking whether your heart-healthy salt is actually a potassium substitute. Maybe it's asking your doctor for a sick day plan at your next visit. Just one. Get that handled, and then come back for the next. Consistency over perfection in your medication and in how you protect yourself. If this gave you even one thing you didn't have an hour ago, hit subscribe so the next one finds you. And tell me down in the comments, how old are you and where in the world are you watching from? I read them, I mean that, and I'm genuinely glad you're here, taking your health seriously. Take care of yourself, you're worth the effort.